Welcome to everybody. It's a real pleasure to share with you this third step of our PCR webinars on the road. We have previously moved to Chennai in India and to New York in US, and we are now back to Europe, exactly in Belgium, to talk about a patient with high bleeding risk and calcified coronary lesion. And it's a pleasure to do this with Dr. Emanuele Barbato from Aalst and my dear friend and colleague, Dejan Milasinovic. The concept of these webinars, it's always the same. It means that we try to move from general guidelines concepts to our really clinical practice in order to analyze clinical and procedural factors that can impact the outcome of our patient. So I would like to ask Dejan to show us the objectives of today.
Thank you, Chiara. So what we are going to be aiming for today is basically discuss two specific cases of patients who have calcified lesions and at the same time high bleeding risk. This is a rather frequent situation in everyday clinical practice. So what we are going to try to explain and discuss is how to have a step-by-step approach for a calcified lesion, to learn about different modification techniques, so techniques for plaque modification. And lastly, but not least, is in terms of prognosis, how to adjust our antithrombotic therapy to what we have done in the cath lab. And we have none else than Professor Barbato, who is very experienced with these kind of patients, to tell us his opinions and to present us his cases. Professor Barbato, very warm welcome and thank you for joining us.
Thank you very much, Dejan and Chiara, for the kind introduction, and thank you as well to host me and host my group and my cath lab here in this series of webinars. Let me just give you some facts and figures. We have 5 cath lab in total here. As you see, we are really on the road. I'm in one of the corridor of one of the cath labs, so don't be surprised if there will be people passing by. There's a lot of work going on here. Together with me, you will shortly see one of my senior clinical research fellow, Emanuele Gallinoro, who's with me here, and he will help me through. There he is, you see him on the screen. He will help me through the presentation of the first case. We do actually these cases together, and he helped me a lot to prepare the slides. So as I said, 5 cath labs, 3 are fully dedicated to interventional cardiology activity. We have quite a busy program, and specifically a busy CHIP program. 3-4 colleagues are fully devoted to that, to CTO, to management of calcified lesions. We have also a very well advanced training program here with 5 to 7 fellows that are alternating every other year. And we are Center of Excellence, as you might know, for rotational atherectomy, hosting at least twice a year courses on the management of calcified lesions. Having said that, without further ado, I hand over with pleasure the word to Emanuele Gallinoro, who's presenting the first case. Emanuele.
Hi, thank you, Emanuele, for the introduction. Thank you, Chiara. Thank you, Dejan. So, the first patient I'm going to introduce is actually a 78-year-old male patient with several cardiovascular risk factors, such as diabetes, dyslipidemia, hypertension, also obesity, and COPD. Actually, he is referred to our cath lab because of atypical angina. And as we can see here, actually, the only criterion that put this patient in a class of high bleeding risk is mainly the age, because he is older than 75-year-old. And as we can see here, the precise DAPT is below 25, it's only 19. Next slide. Here we can see the CT angiography performed before the procedure. The CT angiography shows on the left panel a calcified plaque in the middle AD. On the right side, we see the circumflex with a long calcification in the proximal part of the vessel. Next slide. And here we go to the coronary angiography. Here we can see the right coronary artery, which is basically small, non-dominant. Next slide. Here we can see that actually the diffuse and long calcification that we saw on the coronary angiography in the proximal circumflex actually is not that critical. We don't see a significant lesion at all in the proximal circumflex. Next slide. On the other side, we see in the mid-LAD a nice focal lesion, very narrowed, but what is worth to notice is that the calcification that we saw on the CT, it's actually underestimated at the only coronary angiography. Next slide. We also measured the FFR in this lesion. Of course, it was significant with 0.49, but the other information that we got is that this is indeed a very focal lesion. So we started to try a predilation with a non-compliant balloon. And as we can see, we didn't get any, we weren't success in this predilation. Next slide. Thus, we performed an OCT, and interestingly, the OCT confirmed not only the finding that we had on the CT, so that we have this calcified lesion in the mid-LAD, but also, as we can see in the panel on the right, that actually it's a very concentric calcification. It's almost at 360 degrees of calcified lesion. Next slide.
So this, I think, up to this point, is a very interesting case, which we actually see on a daily basis in our cath labs. But there is already one decision that has been made in terms of the treatment of these calcified lesions, which I think needs to be further discussed. So basically, the first decision that was took was to use the NC balloon, and upon its failure to dilate the lesion, OCT was used to clear the things up and to better maybe assess and evaluate what was at hand there in terms of the calcified lesion. And I think it is important to note here that if we use an OCT or IVUS, for that matter, to better assess the calcified lesions, we need to be aware of several parameters that have been shown to be associated with stent expansion when treating those lesions. So it is not the same if this is concentric calcium or not. What you see here in terms of calcium, it is more than 180 degrees. It is in fact more than 270 degrees. It's almost 360 degrees. And this is important in terms of both the prognosis of the stent expansion, but also in terms of practical use, which devices for plaque modification can be used. What is the difference between OCT and IVUS here is the fact that with OCT, you can also say how thick the calcium is. Whereas on IVUS, you basically can locate the calcium. You can, of course, say how long it goes if you use the longitudinal dimension. You can also say whether it is concentric or not. You can, in some cases, even assess the depth of the calcium, but you're much more accurate for assessing the depth with OCT. And for sure, you can assess the thickness of the calcium much better with the OCT. So our questions for Professor Barbato, for example, in this case, were twofold. First, why did he and Emanuele opt to use intracoronary imaging after failed dilatation with the NC balloon? And the second is, why did they opt for OCT instead of IVUS in this very case?
Thank you very much. That's actually raising a very good point from the onset. Let's not forget that here we had some background information deriving from CT coronary that was already showing some degree of calcification there. That has, in a way, influenced the further management of this specific patient. But I don't want to escape your question. Why to move on with non-compliant balloon first? It is my attitude in elderly patients when there is the minimum suspicion that there is some calcium there, even if the angio was not so clear in this particular case, is to try to play safe and probe the lesion with a non-compliant balloon. We know that these balloons decrease, if possible, the risk of dissections. You know, the worst you can have is dissecting the vessel at that stage and close the door to a number of options that can come afterward. And that moment, if you see an undilatable lesion, because that's what we are talking about here, then the choice is, if you have imaging readily available, then use it. As it was the case in our patient. We had OCT available, we opened the probe, we just got in, and we understood what was the true reason behind the undilatable balloon dilatation. But it can happen very often that you do not have imaging readily available, and so what? What is the next step? My next step, and we can discuss about this, would be in undilatable lesion, no doubt, to use rotational atherectomy. So irrespective of the results of OCT, but OCT in this case was reinforcing this belief.
That's I think very important. The very interesting poll that we just had on the chat, and there are several people joining us now in the chat box. The poll was what would be their next step after seeing that the NC balloon did not succeed in dilating the lesion, and most of the people, actually more than 60%, were voting for rotor ablation upfront. So their next step would be, without imaging, proceeding with the rotational atherectomy. So my question to you would be, although, could we have pondered maybe a larger NC balloon? This was a 2.5 NC balloon. Would that be an option in this case?
No, I would not push the envelope further than that, because if we had good luck once, not dissecting the vessel, it might not be the case after a larger balloon dilatation. So once you see that the lesion is not opening up, then the threshold to use plaque modification tools and techniques should be lowered. So in this case, no doubt, just go ahead. If you have rotational atherectomy, use that one.
Okay. And the second question, actually, that we saw was, which information is most valuable for you from the intracoronary imaging in terms of deciding what to do next at this point of the case?
What CT and the angiogram and the fact that the balloon did not expand cannot provide us as in terms of information is the calcium distribution. So we know that there is a lot of calcium, it's clear. There is so much calcium that balloon doesn't expand. But first of all, how deep is this calcium in the wall? Is it a superficial calcium ring? Is it a calcified lesion that goes deep into the media? That's the first important information. Is there a calcified nodule? Yes or no? That's another important information. For how long does it extend, this calcified lesion? Because sometimes what we can see is just the tip of the iceberg that does not allow the balloon to expand at a very focal point. But once you solve that, then you find out very often that the calcified lesion goes way beyond that very focal unexpanded balloon. So all these kind of informations are difficult to obtain just based on the angiogram, just based from the indirect information you get from the unexpanded balloon.
Yeah, indeed, for length.
Chiara, one question.
Yeah, I think that the choice of the OCT was above all to understand the depth, the thickness, and the extension, the length of the calcium, because I think that from the CT we can see that yes, there is a focal amount of calcium in the mid-LAD, but there is even diffuse calcification before. So I think that OCT was the right choice. Just a question, so you didn't start with an upfront rotational because you started with an NC. So I would just like to know how you change your gut wire, because we know that it's tight anyway, the balloon didn't pass, you have a 2.5, so maybe you can use other tool to advance, I don't know, a microcatheter, but I'd like to know what you do in your practice in order to choose a Rotor wire.
You know, that's a very good practical point. If you have the luxury of using without problems microcatheter, that would be my preference as well. You open up a microcatheter, you advance it through, you pull it out, and then the next is a Rotor wire, which is 3 meters long. So you don't need to do any kind of trapping balloon technique to do this switch. You know, you just pull out the regular B&W wire and you push in the Rotor wire over a microcatheter or over the wire balloon. Alternatively, a cheaper solution is you leave the guide wire in place, the workhorse guide wire, take a rotor wire very gently and try to slide it through next to your workhorse wire. Very often it works. You need to have patience. If you're not in a hurry, it works, and then you spare one microcatheter. That's the other option.
Okay.
So we have talked so much about the rotor wire that I cannot wait to see your next step, which I'm now practically anticipating already. So please show us, what was your next step?
We forgot to mention our procedural setting. I was transradial in this case. It's an extra backup guiding catheter, 6 French, 3.5. Rotor wire floppy is in there, and as Chiara anticipated, it was switched over the use of a microcatheter, and we started with a step-up approach. We started small, and we can discuss the reason why we started small with a 125 millimeter bar, and we went up to 1.5 millimeter bar. That was our treatment for this particular patient. And I give this back to you now, Dejan, to discuss it.
Yes, this I think was an important step. So we already have people in the chat box preparing to ask many questions related to this. The questions so far are related to the type of imaging, why IVUS or why OCT. I think we have talked about that extensively. So at this point, what we know is that we have a near circumferential calcium ring at the medium LAD, that the balloon did not inflate, and that the operators decided to go with the rotational atherectomy. Now, what I would like to discuss with you and with everybody who is watching is that it's not a simple step to just place the rotational atherectomy and be done with it. There are at least 3 crucial points which we are now going to list, which I think all of us need to be aware of before starting with rotational atherectomy. First, and Chiara already talked about this, we need to exchange the wires. We need to place a rotor wire into the vessel, which is different from our host wire. As you can see, only the finishing tip of the rotor wire is 0.14 inches in diameter, which is something which we are used to for our workhorse wires. The remainder of the rotor wire is thinner, and this has implications in terms of practice because you can easily or more easily break it, at which point you would need to take it out and exchange for a new one. But here are the 3 points that are really, I think, important to be mentioned. First of all, we need to be aware what is the guiding catheter that we have in place. Is it a 6 French guiding catheter or a 7 French guiding catheter, or in what shape of a guiding catheter we have? Because if there are many curves, for example, for Aalst catheters, we can have problems in advancing the Burr, especially if we do it from the radial, where there is a tortuous subclavia, for example. This can add complexity to our intervention. The second point we need to be aware of is which Burr we take in relation to the artery. Not only in relation to the guide catheter, but also in relation to the size of the artery. What is the Burr size to artery ratio that should be preferred? And I think there is no one better to be asked that question than Professor Barbato, who is the first author of the EAPCI consensus document on rotational atherectomy from 2015. And the third question that we have, now that we have accessed the coronary artery with the Burr, where should we begin to rotablate and how should we do it? How should we advance and how should we go over the lesion? So Professor Barbato, can we ask you these 3 questions from your experience? How should we think of those 3 focal points when using rotational atherectomy?
Thank you very much, Dejan. These are 3 important points that we tried to highlight in our consensus document. If I can have back the slides that Dejan has just showed, then I can go through the 3 questions. So first of all, guiding catheter diameter and shape. This is a very important point. It depends what is the bar to artery ratio, the target bar to artery ratio you want to achieve. We know that there is a relationship between diameter of the guiding catheter and final bar size that you want to choose. Let's keep it simple. Most of the rotational atherectomy can be achieved with a 6 French guiding catheter. So because we aim at plaque modification, so 1.15 millimeter bar can easily be achieved through a 6 French guiding catheter. But if you think you are anticipating to use bigger bar than that, then you better go to 7 or even 8 French guiding catheter. In terms of shape, you better use single curve guiding catheters. Just to give you an example, extra backup works very well, but if you use already the Aalst guiding catheter has a double curve, you might need some tips, to handle a bit the guiding catheter in order to reduce the friction that you might encounter, especially when upsizing the bar in going through that very last segment of the guiding catheter. So single curve guiding catheter. Question number 2, bar to artery ratio. We aim at plaque modification. This means that we aim to achieve a 0.5, 0.6 bar to artery ratio. That's more than enough. So just to give you an example, for a 3 millimeter vessel, you should be fine with a 1.5 millimeter bar. That's more or less the example. Last, the coronary artery access, okay, that's something we touched upon. And the bar advancement over the lesion, you already saw what is the trick there. Don't cross, especially long calcified lesions, all at once, if you do not want to take the risk of bar entrapment. Just if these are long calcified lesions, do that stepwise per segments, and then each segment do within the coronary with this pecking motion, this movement forward and backward that would reduce the risk of bar stalling and would also minimize the risk of distal thromboembolic complications.
Thank you for this. If I may now relate to some of the questions from the chat box, and there is one from Christian, which I think is important to be clarified. So his question is, can you please clarify the order of the device that you used so far? So his concern is maybe that you used a rotablation rotablator after pre-dilating with an NC balloon. So the question is, can we do that? Or should we avoid, or should we go straight up with the rotational atherectomy before any pre-dilatation?
That is a very good question, and I thank the colleague to have posed that. You know, if you know upfront that you're dealing with an undilatable lesion, then you better start with rotational atherectomy upfront. And you know, the more you gather experience with calcified lesion, the more you can perceive. I would say you can smell, because there is not a golden rule that tells you, okay, this is the angiogram that if you do not use rotational atherectomy, you won't be able to dilate the lesion. It's something you learn by experience, and sometimes you find out in the middle of the procedure. That's the problem. Even in this case, you saw the discrepancy between coronary CT and coronary angiogram. On the coronary CT, you could anticipate that we would have found a lot of calcium on the coronary angiogram. But the point is that so far, we base our decision-making on the coronary angiogram and on intravascular imaging. We still lack evidences. We still lack really support from the coronary CT really to justify and anticipate the use of rotational atherectomy. Unfortunately, we are not yet there. We are working on that. That is the reason why I prefer to start, when I'm in doubt, with a non-compliant balloon, 2.5. It's even undersized for that vessel. Gentle pre-dilatation, and most of the times I don't have major dissection. And by the way, OCT confirmed that I didn't have major dissection. So no problem to switch to rotational atherectomy thereafter.
Chiara, for you, the question, I think, also in the chat box. If you have an uncrossable lesion, what is it that you do in your practice? So not undilatable, but uncrossable lesion. How do you manage to solve that problem?
Well, for the uncrossable lesion, indeed, I mean, you have to try indeed to put a guide wire at the end of your vessel, at least. But in my experience and in my center, when we really try to cross the lesion with a workhorse guide wire, and we cannot advance maybe a rota wire, the tools that we have, it's the laser at excimer. So this is the only thing that we use. Another skill that I get in my experience, you can try with the small non-compliance balloon and try with the shoulder of the balloon to crack a little bit your plaque of calcium. But it's something that you can learn with the experience, and when you really cannot pass a microcatheter, I think that you have to look around what the other tools you have in order to cross the lesion. But it's what I do in my clinical practice. So if I cannot pass a microcatheter, I try with laser. I don't know what the
Professor Barbato, what is your comment on that? That's a question in the chat box. So basically, if you cannot cross with a balloon, what is your next step? Is rotational atherectomy your next step, or laser, as Chiara said?
Well, I honestly, I don't have laser in my lab here, so my next step would be rotational atherectomy, and the very issue there is how to cross the lesion with the rotor wire, because if the guide wire is true and you find out that it's not crossable, if it's not crossable with the wire, it's a CTO, so or a functional occlusion. But if your wire is true and nothing goes through, not a microcatheter, not a Corsair or these special microcatheters, then still what you could do is try to get the nose, really the tip of your microcatheter as close as possible to the CTO, and then or to the subocclusion there, and then try to advance the rotor wire very gently. And most of the time you manage.
Okay, so maybe we proceed further in the interest of time. One of the questions raised was which burr size did you use? And it was 1.25 first, and then 1.5. So what is the difference? And I think here it is important that we once again relate and remind ourselves of the main principle of rotational atherectomy, and that is physically there are two different diameters. So the distal diameter will be a little bit larger than the proximal diameter of the burr head, and it is in comparison with the kokeshi Japanese doll that is depicted at the bottom of this slide that I think you can easily remember it. So if you go with the head across the lesion, as you can see now here, you may get stuck. And this is, I think, one thing that we should bear in mind. If we use a smaller burr, like the blue one on the upper side of the slide, in relation to the green one, which is larger, then what we can do is cross the lesion without ablating it, and we can get into a position where we are not able to retract the burr. The point is, we cannot ablate with the proximal side of the burr because there are no diamonds on it. So we can only ablate with the distal part of the burr, as you can see in green on the bottom side of the slide. So now I think we should go back to Aalst virtually to visit the cath lab. Maybe there is a surprise for all our participants today there.
Yeah, actually, we tried to make an effort of creativity there, and with our limited resources, actually with an iPhone, we managed to have Emanuele connected from the cath lab. Emanuele, if we can have the image of Emanuele full screen, exactly. So, Emanuele, back to you. What I'd like to ask you, if you can have a very short demonstration of the Rotor Pro system you have in your hands and illustrate what are the main points. Please go ahead.
Yeah, of course, Emanuele. So basically, this is the station of the Rotor Pro that we have on the table. That's it. So actually here we can move. And probably here you can see, so just by moving this notch, sorry, it's difficult to, okay. So here we can unlock and move back and forward with the burr. I hope you can have the idea of how long we can move this burr, actually.
It's very clear.
It is quite a long movement along the coronary artery tree. So that's it. This is a 1.5 burr. And we also have, in this case, for the Rotor Pro system, the Dynaglide mode that reduces the number of rotation per time. As you can also hear from the noise, it's quite difficult. It's quite different. This is the noise of the Dynaglide that you can use to advance across the catheter, or when you want to just pull back the burr in order to exchange it. And this is the noise that you have when you use the rotational atherectomy mode, so with a higher number of rotational speed. I hope you can also hear the difference.
Okay, I think it was very well done given the difficult circumstances, Emanuele. Thank you very much. Back to you, Dejan.
There is yes, thank you for this demonstration, which I think nicely showed that there is quite a distance that we can cover with the rotational atherectomy. So there are two questions that I think could address based on what we saw on the demonstration that we saw. The first one is can we use Dynaglide, as mentioned by Emanuele, to get into the coronary artery? What is your opinion on that? Because I've received actually many questions in this respect. If the people could use Dynaglide to get to the mid-LAD more easily through the catheter, the left main and the proximal LAD, and then rotablate. And then the second question, and this feeds into our next segment, is when is it safe to place a stent? So let us first go to the first question regarding Dynaglide.
Dynaglide, yes, you can use it to move upward your bar up to the tip of the guiding catheter. I would strongly discourage anyone to use Dynaglide in order to advance the bar within the coronary artery. You know, you might be tempted to do so if, for example, the lesion of interest, the calcified lesion, is in the mid-segment of the coronary artery, and you have a proximal segment that does not need to be really rotablated because there is no calcified lesion there. So one might think, you know, to get there, I stop with my Dynaglide just up to the lesion. Don't do that, because that's the best move you can do in order to have your bar stuck within the coronary artery. So do that till the tip of the guiding catheter, but from that moment on, just go in rotablation mode. That is to answer your first question, Dejan. And what was your second one?
So the second one is basically, what did you do next? Is it safe to place a stent after you rotablated with 1.5 millimeter Burr? That's it?
Not at all, not at all. That's only you are just not even halfway your procedure, because plaque modification is much more than just rotational atherectomy. Sometimes the nicest part comes after, and perhaps we can go back to the slide. Yeah, this is actually what we did after the two ablation. OCT pullback, you see we did something. There is some dissection there, some disconnection of calcification, but still you see on the right part that there is still this circumferential ring of calcium, as highlighted by the red ring that you almost see closing the circle. The only point where it's not closed, the red ring, is where you have the guide wire artifact. So we are not yet done. This is what we did next, and you can disagree with me, but I can give you the rationale for doing that. What we did next is we went back to balloon, non-compliant, 320, still the waist, then cutting balloon, 310, still the waist in the balloon, and only with the OPN balloon, 315 up to 30, 35 atmosphere, we managed to crack this plaque. And this is actually the initial angiographic result you see after the OPN balloon dilatation. Chiara.
Well, Emanuele, I think it's a point of reflection, because indeed you used OCT in order to check what Rota did in your vessel, and you found out that indeed the thickness of the calcium was reduced after the Rota, that you had some dissection, and even if you had some dissection, you used more tools like the cutting and the OPN. At this point, I think that we have to understand that, yes, absolutely, we have some tools that we can use, but we have to know them, because not always we can use them. And if we use them, we have to control the movement, because OPN, it's high pressure balloon. In my personal experience, I don't have a lot of experience with them, but I think that you can arrive until 40, 50 atmosphere. So you really have to know what you're doing in the vessel. And when you use coring or cutting, you are using some atherotome in order to crack your plaque. But in particular, the cutting, you have to pay attention, because in the eccentric distribution, and if you have dissection, you can augment your dissection without cracking the calcium. So I think that there are tools that we can use. We absolutely have to know that we can use them, above all before placing a stent. But the question is, how can I choose between them, and which is your choice, using before the cutting and then the OPN?
So yeah, that's a good question. You know, when you are in the middle of such a complicated procedure, you use all the weapons at your disposal. OPN would be, in my opinion, the last resource, and that was indeed the last resource. Of course, one question could be why you didn't upsize your bar before moving to these balloons. I was only with 1.5 millimeter bar. I could tell you that the reason is because I had chosen a 6 French guiding catheter, but that's not the true reason, to be completely honest with you, because I could have switched to a bigger guiding catheter. That's not a problem. The true reason is that the day before we had the rotablator workshop at our center and we ran out of bars. We didn't have bars bigger than 175. We used them up all at the occasion of the educational training courses we had the days before. So we were forced to move on with what we had. And that's why we went on and used a cutting balloon. It didn't manage. You see, the calcium was all around and it was very superficial, at least from the OCT, but it was going also deep. And the OPN eventually did the job.
There is several questions in the chat box that I think we could address. Several you have already addressed. So people were asking, Shahin was asking, why didn't you upsize the Burr? So, and you explained why not. But one of the messages I think that should not go unnoticed, and I think it's a big one because this was explicitly the question from the chat box is, how do I know after rotational atherectomy that I have been securely dilating the artery and am now ready for stenting? So this, I think, is one of the landmarks of any procedure in calcified lesions patients. And I think you described it nicely. But the question is, if I do not have intracoronary imaging, because your decision-making in this case was tied and aided by the fact that you had intracoronary imaging. And on OCT, you could see that even though there were some cracks, and Chiara actually nicely showed that there was a crack in this calcium, that there was still a ring of calcium there, very thick. So the question is, can we use a balloon, NC balloon, as a surrogate on angiography? So if we have adequate NC balloon expansion with the diameter that we plan for the stent, if this balloon expands nicely, that we can proceed with stenting.
You could consider this as a proxy, as a poor man intracoronary imaging. If the non-compliant balloon nicely expands, it's already a feedback that you nicely modified your plaque. If it does not nicely expand, then you need to do something more. But again, gentle expansion, you can really probe the plaque. You can really understand how does it look like. And then if you decided to stop rotablating, like I did, I said, okay, I'm done because I don't have bigger bar in this specific case. Then you go aggressive and you take cathy balloon, OPN, and you really try to crack the residual calcification in order to facilitate stent implantation.
And one other question that I've been asked basically is at the beginning, we had this poll early in the case, what is your next step after the first balloon does not dilate? And options were different, cutting or scoring. Could you have used a cutting balloon earlier on in the procedure instead of rotational atherectomy? And can you, after you're done with dilating, after you're satisfied with dilating without a major dissection, use drug-coated balloon to finish this case? So these are two different questions that arise.
I wouldn't use drug-coating balloon in these situations. If possible, always end up with a stent. And concerning the cutting balloon, I'm not sure the cutting would have crossed this lesion. You see, it has a cutting balloon is bulkier than certainly a non-compliant balloon, and also sometimes bulkier than an OCT probe. And I'm not sure I would have crossed it. But yes, it's an option. It's an option to probe the lesion, to try to treat the lesion with a cutting balloon. If you don't have rotational atherectomy, you have to manage in a way. And it would not be a shame to say, I stopped the procedure, I rescheduled the patient after all this patient was stable, when I will have available all the necessary equipment and expertise in-house in order to do this patient optimally. That's also an option, just to stop and reschedule the patient.
Okay, thank you. Maybe we move on in the interest of time. So how did you finish the case?
Yes, from now on, it's about balloons and stents. You see long stents with post-dilatation. That's a very important step. Don't think that just placing the stent is enough. You need to make sure that your stent is well expanded as much as you can. But even then, you do not reach a perfect circumferential shape. But at least you try to reduce the eccentricity as much as you can. This is the final angiographic result. And I show you also an OCT pullback, I guess. You see, it's not bad. It's not perfect, but it's also not bad. We reached a decent minimal stent area. We tried our best to oppose the stent to the wall. We do not have edge dissection. So I don't think we can ever reach a perfect circumferential result in these kind of cases, Dejan and Chiara. Back to you, I guess.
Yes, thank you. So what we closed this case with is the fact that this was an HBR patient. So it was an old patient, and according to many HBR criteria, this would probably put him in the high risk of bleeding, although age alone is seldom, at least according to HBR-ARC, the major criterion. It's a minor criterion, but if there are other criteria, it could be really a high risk of bleeding. So what our goal is short DAPT in such patients. And I think one of the purposes of this webinar is to draw attention to the fact that in order to be sure that the short DAPT is not going to be associated with higher risk of ischemic events, we need to be sure that the intervention, that the procedure was done correctly. So whether the type of a stent plays any role in there are studies with different types of stents that have been associated with favorable outcomes. But I think that the technique is also very important. And I think this is what has been shown in this case. We should also aim for correct stent expansion in these patients. So I would proceed further because we have another case, and this another case will be related to some of the questions that we have also received. So let us have the final slide as a closure of the first case. And this is the slide showing that we have clinical and procedural factors in every intervention, every procedure that we have. And the fact that this is a patient with a bleeding risk is something which is given to us. What we can impact on is the procedure. And we can choose the plaque modification strategy, and we can use invasive imaging in an effort to optimize the procedure so that we can have as short DAPT duration as possible. Now I would like to ask Emanuele to show us the second case for today, which will be shorter, but also very interesting.
Yes, basically, this case is quite different as compared to the previous one. Now we have an 89-year-old lady with a medical history of breast cancer in 2008, which was at the moment of the procedure and currently metastatic, under treatment with both radio and chemotherapy. She's in permanent AFib and using as anticoagulation apixaban. So in this case, it's a very high bleeding risk presentation. As we can see that the precise DAPT is above 40, it's around 45. But we also have other conditions that contribute to increase the bleeding risk of our patient, such as cancer, the age above 75-year-old, but also persistent anemia with an hemoglobin below 9 grams per deciliters. She was referred to our cathlab because of recurrent chest pain. Here we can see that in the left coronary arteries, in the circumflex, there was only a diffuse atheromatosis without any significant stenosis. Next slide. As well as in the LAD. There was a plaque, a mild stenosis in the proximal part, in the mid part, right beyond the diagonal branch, but that was measured and the FFR was negative. Next slide. Then when looking at right, we can see that there is a nice block of calcium in the proximal right, extending towards the ostium of the coronary artery. So, next slide. Emanuele.
Well, thank you very much. Actually, what we did here, and we can again discuss about this, adopted a completely different strategy in this case. We opted for intravascular lithotripsy, and the main reasons for that are related to the fact that this is a large chunk of calcium in a large vessel in the proximal part of that vessel. So all these arguments, in a way, convinced us that this was a perfect candidate for this technique. That the treatment was with 312 shockwave balloon. We did 4 cycles of lithotripsy. And I give back the word to you, Chiara.
Indeed, Emanuele, it was very brave to put this lady on table, and it was maybe very smart to use the shockwave, because even if you didn't perform any imaging in this case, and I can imagine because of the high bleeding risk, so to reduce the time of the procedure even, we can see that the calcium is a real block of calcium, so maybe circumferential calcium. And we know that the tools that we have talked about, like the OPN and the modified balloon, can crack the calcium, but they cannot open the deep calcium, while the shockwave can gently and maybe safely disrupt both, because in terms of function, it's a mechanical way of disruption with these sonic waves that gently are absorbed by the calcium. So you have calcium fragmentation in all the circumference of the vessel, and we know from studies that you don't have any embolization, so you really reach the crack of the plaque in all the extension and the depth of the vessel. So I think it was a good tool, and it's important to know and to have it, even because you don't need any real practical skills, because it's a balloon. It's a 12 millimeter balloon, so maybe you cannot use it in all the anatomies, because if the vessel is very small or maybe angulated or tortuous, you can have some problem in sonic waves release. But I think it would be a very good choice. So I'd like to know the final result.
Thank you very much, Chiara. There is, if we go back to the slide, there is just one point on which I slightly disagree with you when you mentioned you do not really need any technical skill. Actually, the use of intravascular lithotripsy should come at the end of a training, of a learning curve. So with this, what I'm trying to say, we should not tackle these complex patients without having at our disposal tools and techniques, complex skills we need to develop, because even a straightforward case like this one can turn into a nightmare if we are not really, if we do not have readily available additional tools, and we cannot apply additional techniques, starting simply from crossing this lesion. It was not that obvious. So I would tend to say that IVL balloon, it's portfolio of a cheap procedure and of a cheap operator. It's not really something that anyone can use to start with this kind of patients. That's my personal opinion, of course. So this is the result. It's just a balloon and stents, 3.518 post-dilated, and the final angiographic result is on the right. So back to you. I think it's Dejan now.
Yes, but before we discuss about the ensuing pharmacological therapy, I would try to go back a step and discuss what we have seen actually in those both combined cases. So the first question that is obvious, and I think this is related to some of the questions in the chat box, is why did you here use upfront IVL as compared to an array of devices that you used in the previous case? So some could argue is that you could have used IVL in the previous case as well, as long as you could pass it through the lesion, which could have been a possibility after the 1.5 millimeter rotational atherectomy. So what brings you to use an upfront IVL? Let us put it that way.
Well, this is the typical example. When there is so much calcium in a proximal part of the vessel, pretty straight segment, so I don't have really problem to deliver my device up to there. And when you anticipate deep calcification, it was mentioned by Chiara before as well. That is the kind of situation where I would use IVL. Here, the use of rotational atherectomy, even with a 175 or a 2 millimeter bar, I'm not sure would have completely modified this calcified lesion. The beauty of this technology is that you really crack this plaque and you reach a much larger minimal stent area in these kind of situations. In the previous case, it was in the middle of the LAD, it was a long calcified lesion, even if there are data, even from the DisruptCat3 trial, that IVL technology works very well in long lesions, we have to say this. Still, that is my own experience. Rotational atherectomy does much better in the case we've shown before, when you have a mix of circumferential calcium with superficial and medial calcification. That is the kind of case where rotational atherectomy would much better modify that kind of plaque.
Thank you. And related to this question, basically, what I think is the major learning that you conveyed during this webinar is that you need to know the whole toolkit. You need to understand different devices and when to use them. And I think I would like to mention that there is very often when I talk about calcified lesions with friends and colleagues, they tell to me there is basically no evidence base. They say, it's nice that what you're doing, but there is really no evidence suggesting that you're doing any good. And I think we should dispel this as a myth, because there is, of course, evidence from the past suggesting benefit, but I think there is also evidence from contemporary trials, like the PCR Calc randomized trial from Germany, which basically show that if you do not use rotational atherectomy, but use instead of that other modified balloons like scoring or OPN balloons, you may end up in a failure to dilate the lesion in up to 20% of cases. So this is direct evidence showing you that you need to be aware that there is a wide toolbox for calcified lesions, and that if you do not know how to use it, you are going to have, in 20% of the cases, failure to dilate the lesion. So I think this is already some evidence from contemporary trials showing that it is important to understand how to approach calcified lesions. And back to some evidence from the past, suggesting that you may even increase the risk of wrist stenosis. And this is why there is a question what to do if you implant stents afterwards. Are you going to have an increased rate of wrist stenosis? One practical aspect is, if you rotablate, like in the first case, should you perform rotational atherectomy only at the focal point of the lesion, or do you do it in a longer segment that is not going to be stented as well?
That's a given fact. To reach the lesion in the medial AD, you have to go through the proximal AD. You cannot just jump on that. And of course, the fact of starting your rotablation from the proximal LAD up to the medial AD in a way smoothens the vascular lumen. You do not necessarily need to stent it all, because that's actually the displacement of the friction. That's the differential cutting principle. So basically, if there is no calcium, then there is no harm to the vessel, because the bar will be just flipped out of that segment, of that elastic segment. Where the bar would act on the unelastic segment. That is where it would work. So there is no issue there to go and start ablating from the proximal to the mid part. And just to come back on what you were reasoning about before concerning the lack of data, actually we do have evidence, indirect evidence, and they are coming from the stent results. If we do not implant the stent correctly, in other words, if we do not reach a good stent expansion, the best minimal stent area possible, lack of each dissection, this is the best predictor of stent failure, of stent thrombosis, of myocardial infarction, of wrist stenosis. So that's the point. In general terms, it is extremely difficult to show a direct clinical benefit from plaque modification technique and clinical outcome, simply because we have a higher crossover rate. There are lesions that we cannot simply treat without those techniques. And what to do next? We would implant a stent that is suboptimal, and that's certainty that this patient would come back with a stent thrombosis or with wrist stenosis.
Thank you. And then one question for Emanuele directly, and then commented by Professor Barbato afterwards. You did not, or did you use, or do you use pre-dilatation with the NC balloon prior to the IVL? Is that a standard or not for you?
Well, actually, it depends. As we know, the profile of this balloon for the IVL is really not optimal. So it's usually, we do usually prefer to do a pre-dilation with a non-compliant balloon, at least to increase the probability then to cross the lesion with this IVL balloon. This is our standard, unless As we did in the first case, the lesion was really proximal, the vessel was a big one, and we just tried directly. Of course, sometimes if you have the feeling that the lesion is calcified but is not that narrowed, of course you can give a try and go directly with the IVL balloon. Most of the cases we are used to do first a predilation with a non-compliant in order to open the way, then to be able to cross the lesion with the IVL balloon.
And this is, by the way, common practice. If you look at the data from this RAPCAP3 trial, nearly 50% of the lesions included in that trial were predilated. But the point is, really, the predilatation serves to deliver the plaque modification tool and device within that lesion. And then the objective of IVL will be with a gentle balloon inflation. Let's remember it goes up to 4-6 atmosphere. It's really to touch the vessel wall in order to deliver uniformly the waves, the lithotripsy, and to break deep calcification. So really the concept is just open up the lumen a little bit, facilitate the crossing of this device. This current generation is still a little bit bulky, but then the device will do the rest of the job.
One of the recurring questions also, and I think I will ask Chiara first to answer that, and then Professor Barbato, is what do you do in case of a dissection when you try to prepare the lesion? I have had a case recently of proximal LAD disease extending into the left main. So our plan was to stent the left main. And I started off with a balloon, with an NC balloon, but I had a large dissection in the proximal LAD, which was a type C dissection, contrast dye staining that was remaining after clearing off from the vessel. So what I opted for is I waited for 10 days and then I brought the patient back. So what is it that you do, Chiara, in cases of extensive dissection with the balloon, but the balloon did not dilate the lesion? That was the problem, of course.
Well, indeed, maybe imaging will help in order to understand where really you had the dissection and how you can treat this dissection. But indeed, I've never left a dissection, so I always try to go over with my procedure to better prepare the lesion that I didn't cross with my balloon with other tools and try to put the stent at the end. But I hope that Emanuele would suggest us maybe better choice to save our patients.
I'm eager to hear, yeah.
Well, I recently heard a quote from Jean Fajadet. The fact of being more experienced is just because we had the chance to make more mistakes and to have more complications. I mean, that doesn't mean we have the recipe of all the troubles. The point is that if you have a dissection and the patient is stable and the flow is preserved, you can do like Dejan did. Just hold on, wait 3-4 weeks, let the dissection seal and take the patient back. And then at that time, you have the chance to choose Rotor, IVL, orbital, whatever you like. But the point is, if the dissection is flow limiting and the patient is unstable, then you have no choice. You have to go on. And go on means, and at times it happened to me, and I'm sure to some other operators as well, you just take rotational atherectomy and dissect and continue to work even if you have a dissection, because the point is to restore the flow. So you have to go on and complete your job, even if you don't like it, even if there is a risk of extending the flap, you have to restore the flow, and then you do what's needed for the patient.
I think that this is an important comment coming from you, because I think this is something which we all will take home for us. So I think we need to close out now this case and then the whole webinar. So if we could have the slides back, please. This is for Chiara to tell us what will have an impact on the long-term outcomes in this case.
Yeah, I think that in this particular case, we have an eye bleeding risk patient, and we cannot change this, an old patient and a calcified lesion. So what we can do is to choose the right tool in order to treat this plaque and to modify this plaque in order to have the best result for our patient. And above all, the medical therapy after the procedure will be very, very important, because for the eye bleeding risk, we know that we now can choose from the triple, dual, or single therapy in order to prevent a thrombotic risk, but above all, an hemorrhagic risk in this patient. So I will let you the word to summarize the two cases of today that were very, very interesting and with a lot of tools to know and technique to use in our clinical practice, I hope.
You will see the conclusion. Basically, we had two cases of really calcified lesions which were connected to a high bleeding risk. And I think a single message that we would like to transmit from this webinar is do your best to have optimal stent expansion without edge dissections, so optimal procedure, because then you can utilize the evidence of short DAPT being favorable in these patients, and you can even try to have an early aspirin drop if you have someone who requires oral anticoagulation. But optimal stent expansion is intimately connected to plaque modification strategies that you have seen throughout this webinar and which I think take time to learn and understand. So thank you once again for watching. Thank you, Professor Barbato. Thank you, Chiara. Thank you, Emanuele. And I also want to thank you, PCR Online and Concept Medical, for their support. We will see each other on October 25th for our next webinar. Thank you once again to all. See you.